So comparative accuracy is of much interest to me because clinical and policy decisions are typically comparative when alternatives exist. And my doctoral and postdoctoral fellowships have been very much about how we can obtain reliable evidence about comparative accuracy in systematic reviews and meta-analysis. I suspect that we've got a mixed audience here, with statisticians and non-statisticians, and also maybe different backgrounds in terms of what your understanding or familiarity is with test accuracy and systematic reviews of test accuracy. But I'll try to be as inclusive as possible. However, I'll assume some familiarity with the concept of test accuracy and statistics like sensitivity and specificity. As I wrote in the summary for the webinar, my aim really is to introduce participants to the challenges of comparative accuracy meta-analysis and current approaches. So this is very much an overview rather than an in-depth into any specific aspect. And what I'm hoping to do as well is to be able to signpost you to useful resources and provide references. So medical tests have been in the spotlight a lot during the pandemic, and depending on where you are in the world, the public probably know a lot more about tests now than they've ever done before. But one thing we do know is that the evaluation of medical tests have lagged behind the evaluation of interventions, and that has been the case too in terms of evidence synthesis. The first Cochrane DTA review was published in the Cochrane Library in 2008. So it's just over about roughly about 12 and a half years ago now. I'm not a particularly good storyteller, but hopefully over the next 45 minutes or so, I'd like to take you on a journey to highlight how comparative meta-analysis has evolved, beginning with a bit of background, especially about comparative accuracy study designs, as I suspect some of you may not really be familiar with different study designs, and also talk about current practice, where I'll address test comparison strategies and current meta-analysis methods, and then finish up with extensions to network meta-analysis of diagnostic accuracy, and I'll be using the abbreviation DTA NMA for that. So in terms of the scope of a DTA review, whether it's a Cochrane DTA review or not, multiple objectives are possible in one review. And there are three types of analyses that are based on the review question and these objectives. So the first one is, what is the diagnostic accuracy of a test? So this is a review that addresses just one test. Another question could be about, how does the accuracy of two or more tests compare? And the third one is about, how does test accuracy vary with clinical and methodological characteristics? So this is really about investigation of heterogeneity. Last year, I looked at Cochrane DTA reviews published in the Cochrane Library up to July 2020. And there were 135 of these reviews. And I wonder, if you were to take a guess, how many do you think evaluated two or more tests? There's no poll for this, but just have a guess. Well, the answer is 79. That's about 59% of the published reviews. So these reviews are being done commonly in Cochrane. And out of this 79 that assessed two or more tests, 54 assessed more than two tests. So that's about 68%. Well, maybe this number isn't surprising in Cochrane reviews, because the Cochrane DTA editorial team, we encourage review authors to address comparative questions where relevant. So that may not be surprising. But also in the wider literature, we see a growing number of comparative accuracy reviews. Of course, not all of these reviews perform meta-analyses, and some of them might just perform meta-analysis of one test in the review, or some go on to do a comparative meta-analysis. In terms of what the primary objectives of a DTA review are, they're usually the first two on this list. So it's either about the diagnostic accuracy of a single test or comparing the accuracy of two or more tests. So when I talk about comparative accuracy, what exactly am I talking about? Well, there are several measures of test accuracy, but the most commonly reported and the ones that we focus on in meta-analysis are sensitivity and specificity. So sensitivity, the proportion of the cases that are correctly detected by the test, and specificity, the proportion of non-cases that are correctly detected by the test. So what we're interested in when we talk about comparative accuracy is how does sensitivity and specificity differ between tests. And also, before I go any further, I just want to clarify terminology, because in test evaluation research, we don't have, there's not a lot of consensus around some of our terminology, and some things may mean different things to different people. But I just want to be clear about what I'm talking about when I say the index test. That's the new test or the test strategy that we want to evaluate. Now, it may not be new as in it's just been newly developed, but it might just be that that test is of particular interest. When we talk about comparator tests, this is the test that we want to compare the index test against. It could be an existing test or diagnostic management strategy that is what is used currently in practice. Now that term, the comparator tests, we found very early on in when review authors submitted Cochrane reviews that there tended to be some confusion over the comparator test and the reference standard. And we've seen this too in the literature. But to be clear, the comparator test is really another index test and not the reference standard. And the confusion, I guess, arises because sometimes actually the only other alternative test is the reference standard. And so the lines get quite blurred and that becomes quite confusing. So for that reason, we decided to get rid of comparator test as a heading in Revman and in Cochrane review. So we just simply talked about index tests. So I might want to compare two or more index tests and don't use the term comparator test. Now the reference standard is the best available way to verify the presence or absence of the target condition. And this may be a single test or a combination of tests and other clinical information that may not even be routinely available in practice. The purpose of the reference test is to tell us whether or not the target condition is present. So that's just about the terminology that I wanted to clarify. And I'll start by providing some context for what comes later by looking at study designs for comparing test accuracy.
So ideally, what we would like to do is to compare test accuracy head to head in a study, which is what I've referred to here as a within study comparison. And we can do this either by using a within subject design, which we often refer to as paired, particularly when we've only got two index tests. And the alternative is a between subject unpaired design. The unpaired design could be either a randomized design, so random allocation, when we refer to that as a randomized accuracy study, or the allocation of tests may be non-random. And for the non-random one, you could have a prospectively controlled or a historically controlled study. And what exactly do I mean by that? It's probably best to give an example. So an example of a prospectively controlled study is, for example, a study comparing CT and ultrasound for appendicitis, where the decision to give a patient ultrasound, CT, or both was based on the clinical judgment of the referring surgeon or the emergency department physician. So this was done in an emergency setting. An example of a historically controlled study is one where they compared both tests by evaluating CT in a prospective cohorts of patients. But then for ultrasound, they used a historical cohort that they retrospectively identified by looking at computerized hospital records. Now the question is this a fair comparison? I don't think so. So these designs differ in terms of how robust they are, but when we talk about robust comparative studies, we're talking about studies that use the within subject design or a randomized design. And a randomized design might look like this comparison here of CT and MRI for coronary artery disease. Here, the reference standard is coronary angiography, and patients are randomized to receive either CT or MRI, but everybody gets the reference standard. And we can then make comparisons of test accuracy between randomized groups. And the results are presented in separate 2x2 tables for each test. So that's a table for CT and a table for MRI. On the other hand, you could have, this is a paired design in which everybody gets all the index tests and they also get the reference standard. And this design is a more common design, and you can think of that in a lot of scenarios. It's possible to use this design because if you're taking a blood sample, you can divide it up and perform separate lots of different tests. So it tends to be quite a common design compared to a randomized design. A good advantage of a paired design is that we can produce a joint classification table like this, where we cross-classify the results of the two tests in the group that do have the condition. So here, those who have coronary artery disease, and then in the group that don't have coronary artery disease, so that we can know what are the concordant results and the discordant results. So although such a table is potentially very useful, studies do not often present results in this format, but rather they give a separate 2x2 table for each test cross-classified against the reference standard, as you saw in the previous slide for a randomized study. Here I've just given an example so that you can see a table with some real data in it. This is from our report of a paired study that compared the accuracy of 2 assays for diagnosis of active TB. And you notice that we even went further, not just given the positive and negative results, but also we gave the inconclusive test results labeled here as indeterminate and missing results as well. And for T-spot, which is one of the assays, we also gave borderline positive results. So a full cross-classification like this, which can be quite useful. For the purpose of our primary analysis, borderline results were considered as positive. And what this table highlights is another challenge that we'll have, and for some methods that I'll mention later, that rely on joint classification tables is this issue of missing data. So what do you do when you've got missing data for one or more of the tests that you've got? Okay, great. So we've got these study designs, but many diagnostic accuracy studies are not comparative. They address just one single test. And in this empirical study that we did some years ago, we found that only about 1/3 of studies in comparative reviews were comparative. Therefore, reviews often relied on studies that have assessed only one of the tests of interest. And so comparative reviews need to be very clear about what strategy they use for comparing tests. And what do I mean then by a test comparison strategy? There are basically two test comparison strategies. One you can consider as a direct comparison, as illustrated here, where in the simple case of two tests, A and B, a direct comparison includes only studies that have compared the two tests head to head, either using paired or randomized studies. And the other strategy is an indirect comparison that uses all eligible studies that have evaluated at least one of the tests of interest. And this approach allows us to maximize use of the available data. But as you can imagine, this is prone to bias due to confounding. A systematic review may include an indirect comparison, or it may also include a direct comparison if they've got comparative studies where they do a second analysis restricted just to the direct comparisons, or they may choose to just focus on a direct comparison only. So those are the possibilities within a review. And I'll use three Cochrane reviews as examples to show different levels of complexity in test comparison strategies in DTA reviews. Now, this first one, which is a review of expert MTB versus expert ultra. So expert ultra is a newer generation of the test. We performed a direct comparison, and here we had only 3 paired studies that had compared the two tests. So this is not a particularly complicated example because we've only got 2 tests. I mean, there were other complexities going on in the review, but in terms of the number of tests, there were just 2. So a pairwise comparison is straightforward here. Now, this example is more complicated, and I've illustrated the test in a hierarchy. So in order to provide a coherent description of the studies that contributed to each analysis, the results were structured by grouping studies at the highest level according to antibody type. So we've got 2 types, HRP2 and PLDH antibody-based tests. Now, each antibody type consisted of test types. So there's 6 different test types. Types 1, 2, 3, and 6 are classified as HRP2 antibody-based tests, and types 4 and 5 as antibody-based tests. And finally, we have brands, and I do apologize if you can't see that, if it's quite small on your screen, and don't worry about it. Basically, I just wanted to show that, okay, we've got brands within types. So we've got 10 type 1 brands, 2 for type 2, 3 for type 3, and there were no brands for type 6. And then we've got 4 type 4 brands and 2 type 5 brands. And altogether that we have a total of 21 RDT brands and 74 studies included in this review. Our analytical strategy therefore compared the accuracy of commercial brands within each test type, and we also made comparisons between types and also we did a pairwise comparison between the two antibody types. So for each level of analysis, we then considered indirect and direct comparisons. Notice that so far I'm talking about strategy. I haven't moved on to talking about meta-analysis yet. Now, in this example of first trimester serum tests for Down syndrome screening, I introduce a network, but not to get too excited, we didn't actually do a network meta-analysis in this review, but just use this network just to illustrate the relationship between, in terms of the studies that we had for each test. So in this review, there were a total of 78 test strategies. So of course, it's not possible for us to put all of that into one model, and even some of those strategies were assessed in just a single study. So we had to narrow down what to compare in one model. And we decided to select test strategies for further investigation if they were evaluated in 4 or more studies, or if there were 2 or 3 studies, but individual study results indicated that performance was likely to be above a sensitivity of 70% and specificity of 90%. Our main analysis here was based on the test strategy of indirect comparison of the 9 selected test strategies shown in this network. And we also performed pairwise comparisons where that was possible. So I hope the 3 examples give a flavor of what you may encounter in a comparative review. And together with the study designs, you're starting to get a sense of some of the complexity of comparing test accuracy. In this methodological review, we examined the characteristics of comparative DTA reviews and provided some examples of good practice. And you might find the recommendations box of interest. So I've just put that as something that you can reference. So now, how can I statistically combine the studies to compare test accuracy? What I didn't ask in that poll is whether the meta-analysis that was done compared test accuracy, but it was really just to get a sense of where people are with DTA meta-analysis. Okay, so we do have challenges in DTA meta-analysis, as those of you who've done them may be aware of. So we've got 2 summary statistics for each study, which is our sensitivity and specificity. And each of these have different implications in terms of the consequences of test errors. So in terms of sensitivity, we've got false negatives, and specificity, we've got false positives. And so we need to think about those carefully. Now, thresholds effects, again, are something that are a challenge because there's sensitivity and specificity are potentially correlated across studies. This is because studies may have used different thresholds for defining test positivity, or even where studies have used the same threshold, or it's a test where you don't get a numeric or an ordinal test result. It's a binary test result. And so you don't have numeric or explicit thresholds. There can still be a threshold effect because of certain characteristics that then lead to these differences in sensitivity and specificity that present as a threshold effect. Heterogeneity is also the norm. So when we don't see heterogeneity, it's a pleasant surprise. What we start off with and what we expect to see is heterogeneity. So we will see this in our reviews. And so the methods that we use need to be able to deal with that. Now, when we come to comparative DTA meta-analysis, we have additional challenges in that DTA's many of our studies are not comparative. I've shown you the different study designs. And where we've got paired studies, we should be accounting for the correlation within patients. and availability of such fully cross-classified data is rare. So those are potential problems. Now, I did a review of methods as part of my PhD, and this is a table that I've taken from that. And what I wanted to do was to identify methods for comparative meta-analyses and to evaluate them. My searches were conducted up to July 2014, so a while ago now. But this table summarizes what I found at the time. Most of the methods in this list have important methodological limitations. And the two that are highlighted in yellow are the two methods that are recommended in the Cochrane DTA handbook. So hierarchical summary ROC meta-regression and bivariate meta-regression. The other three methods at the bottom of the list, the Cheng 2013 and Verdi 2013, they were conference presentations. And Cheng, that was, like to say, that's probably the first mention of a network meta-analysis of DTA studies. Verdi looked at bivariate meta-analysis of paired data, and Tricholinus also did the same with in the approach that he proposed. And we'll talk a bit. I'll come back to the approach by Tricholinus later on. So this was what was available at the time. Of course, since my methods review, there's been other publications, and I'll come back to that. But for now, I just want to look at hierarchical meta-regression. So this is what's recommended in the handbook. And because these hierarchical models, they're regression models, they can be extended by adding a study level covariate. So we can add a covariate in for test type and use that as a means of comparing test accuracy. Now, depending on the model, we can address different questions. If it's the bivariate model, we can look at differences in summary points of sensitivity and specificity. And I'll show you the model specification for that. For the HSROC model, we can look at differences in overall accuracy, in threshold, and in the shape of the summary ROC curve. So really what we can do with meta-regression depends on the parameters of the model. As an example, because you look at these two, CT versus MRI for coronary artery disease. In this review, there are 89 studies of CT and 19 studies of MRI. And out of all of the studies in this review, 5 of them were comparative. So actually, it's 103 studies included in the review. And you see the scatter of the study points in ROC space. Now, for this other example, this is BMP versus NT-proBNP for heart failure. There were 20 studies of BMP, but the studies used different cutoffs, and altogether there were 16 different cutoffs. For NT-proBNP, there were 16 studies, and they used 13 different cutoffs. For CT versus MRI, we can assume that there's a common threshold. And so it makes sense to estimate a summary point, an average sensitivity and specificity, whereas that isn't the case for BMP versus NT-proBNP, because that, if we calculate as a summary sensitivity and specificity, then that's not particularly meaningful because it doesn't relate to any particular cutoff. For the bivariate model, the focus of inference is the primary objective is to compare summary points, while for the HSROC model, because we've got those differences in thresholds, the objective is to compare summary curves. So, well, it's a webinar for the statistical methods group. I thought maybe some people will be keen to see equations and a bit of Greek. I do apologize if that's not the case. But then again, really, my intention is not so much the equations, but just to highlight the parameters of the model. So for the bivariate model, we model the proportion in each study that have correct test results in the diseased and non-diseased groups, so the number of true positives and true negatives are modeled at level 1, and then we allow for the between study variation at level 2 through the inclusion of random effects. Now this model has 5 parameters. So this is the basic model without a covariate for test type in. So we're not talking meta-regression here. We've got 5 parameters. We've got the mean logit sensitivity and mean logit specificity, their variances, and then we've got a covariance of logit between logit sensitivity and logit specificity. Now, when we extend this model by adding in a covariate, we can include a covariate that affects both sensitivity and specificity. And we can also allow the covariate to depend on the variance parameters so that we're not assuming that there's a common variance across different test types, but we can allow each test to have its own variance parameter. Of course, the more flexibility and the more parameters you allow in the model, then the more complex it becomes. And of course, you have to think, do you have enough data to be able to fit the model? Back to the CT versus MRI examples, this is the result when we just restrict the analysis to a direct comparison of the 5 comparative studies, and the result when we include all available studies, all the 183. Thankfully, in this case, the results are consistent. The only difference really is that, or rather the main difference is that from the indirect comparison, you get less uncertainty because you've got more studies in the analysis, but the results are in the same direction. Now, earlier I showed you a network plot of for the Downs review, and what we did again there, we used a meta-regression model, and because these studies all used the 5%, the reported sensitivity at a 5% false positive rate, what we actually did was not a bivariate meta-regression, but a univariate meta-regression to pool the sensitivities, and then summarize the results on this plot. Just for completeness, the names of the different tests on there. And each circle represents the summary sensitivity for the test strategy, and I've scaled it according to the proportion of to the number of Downs cases. So really, this just shows the different sensitivities, and of course there are some studies for some tests we had very few studies and few participants, whereas for others there were a lot of studies. So that's what we did here. We didn't do a network meta-analysis. I'm going to skip the HSROC model specification, again just included here for completeness. Here again we've got several parameters. The HSROC model without the covariate in it has got 5 parameters: the threshold, accuracy and shape parameter, and also we've got variance parameters for threshold and accuracy. And the model can also be extended by including covariate terms for accuracy, threshold, and the shape parameter. And when the shape parameter is assumed to be 0, then what we're actually saying, the covariate term for the shape parameter is assumed to be 0. What we're saying then is that all the tests have the same shape. And sometimes we do have to make this assumption because we don't have enough studies in there to reliably estimate different shape for different tests. And if we do that, then we can express the relative accuracy using the relative diagnostic odds ratio. So that's just a quick whiz through of HSROC meta-regression models. And there's a non-technical summary in this paper for those who are interested in knowing a bit more about these models. Also, on the website of the methods group, we've got a software page, and we've got programs and tutorials on there for R, Stata, and SAS on how to fit these models. So now let's think about network meta-analysis very briefly. Can I do a network meta-analysis of diagnostic test accuracy? My answer to that is yes, you can. What are the methods that you should use? Well, this is where I pause and hesitate then. Because since my methods review, more NMA models have been published. However, we know little or nothing about their validity and properties, so it is premature to make recommendations for their use in practice. A review and evaluation of the models is ongoing. This research is led by Aggie and co-funded by Greece and the European Union. And thanks to Aggie, Sophia, and Dimitris for inviting Goethe and I and Reedy from our team in Birmingham to be involved in this project. So really, if you've got any questions about network meta-analysis of DTA, Aggie is the best person. It's a good thing she's hosting this, so I might deflect some of those questions to her. Thanks to Aggie and Sophia too for sharing some of the slides I'm going to show now. So we searched PubMed, Web of Science, and Scopus from inception until the end of July 2019, and also looked at relevant unpublished material, because some of the work that's been done around NMA DTA methods have been done as PhDs. We identified 10 methods paper and 40 empirical studies that had applied one of the methods, and this tended to be the hierarchical meta-regression methods. As you can see in this table that summarizes key characteristics of the method, since the Tricholinus paper in 2014, several DTA NMA models have been published, and these models extend the original hierarchical models that I showed you earlier, whether it's the bivariate or the HSROC model. But notably, when you look at this table, all but one of the methods are Bayesian hierarchical models. Tricholinus extended the bivariate model to an ARM-based multinomial model approximated using a multivariate normal distribution for the joint meta-analysis of studies comparing multiple index tests on the same participants. So this model requires joint classification tables. Remember, I showed you earlier. Now, for studies that only report sensitivity and specificity of each test, counts for the cross-classification are imputed based on the associations observed in studies that report the full cross-classification. Now, Ma in 2015 proposed a hierarchical DTA NMA model using a missing data framework to incorporate studies of any design, including studies with or without a reference standard. In the paper by Menton, they described 5 models, but only 3 of the models allow for comparisons using direct and indirect comparisons. And those are the ones in this list here, the A, B, and C. So A assumes a perfect reference standard, as you can see in the imperfect reference standard column, while models B and C allow the use of an imperfect reference standard. But all 3 models ignore the correlation between tests from the same study. Of all the models in this table, this is the only approach that is contrast-based. All the others are all ARM-based. Model A allows direct and indirect comparisons, and indirect comparisons are obtained through common comparators. B and C are hierarchical latent class models, and these latent class models use the number of subjects showing the pattern of outcomes across the test instead of the number of true positives and false negatives per test. Cheng also proposed 3 models, and Model A is a multinomial model which decomposes the true and false positive rates for each test on the logit scale into components that represent their overall average across study types for each test. And in the model, you can include single, paired, triple test studies and use it with or without complete joint classification tables. And then model B is an extension of the HSROC model, and model C uses beta binomial marginal distributions to model the observed number of true and false positives. I'm conscious of time, so I'm not going to go into all the other models, but briefly, just to say that the DMU model uses a multivariate normal distribution on the logit sensitivity and logit specificity to account for the within study covariance. And it's kind of similar to the tricholinous approach in that you can extend it to more than 3 tests, but they're quite challenging because of the when you allow for multiple correlations between tests. Inyaga proposed a 2-stage arm-based hierarchical model that uses the logit transformation of sensitivity and specificity. And then in a second paper, they proposed a 1-stage arm-based approach where they use a copular model to describe the dependency between sensitivity and specificity. The Owen approach is an arm-based approach, and it's similar to the Inyaga 1-stage model, but the Owen approach allows for multiple thresholds per study for a test. Lien extended the Bayesian HSROC model to network meta-analysis to compare multiple tests, and they use a missing data framework and also account for correlation between multiple tests. So I hope that gives you a flavor of what's available currently, and it's possible that maybe something else has also come out in the literature since then. But this is really where we are right now. Aggie has looked at evaluating the different models using a case study in cervical cancer. Now, because as you've seen, the different characteristics of the different models, so it wasn't possible to look at all the models, and they looked at 4 of the models as well as hierarchical meta-regression in this using this case study. I'm going to skip this because I've already talked about the models. This is a network plot of the 3 tests that they applied the models to: cytology, HPV DNA, and mRNA tests. Now, as you can tell, most of the studies have compared cytology and HPV DNA. There are 32 studies, that's the dotted dash lines, and then 4 studies that have that compared the 3 tests, and there was a single study that looked at only cytology. So the summary of what they found is that different methods lead to different results. This might be because of the approaches that the models take into how they deal with heterogeneity, and also how the model's sensitivity and specificity, whether they're using the logits or they're actually modeling them as proportions. And then again, the choice of method will depend on the available data. So even if you want to model, you've got paired studies, but if you don't have the cross-classified data, then you wouldn't be able to use that particular approach. So for anyone who's traveled in a long car journey with a child, you can sympathize with the driver here. And over the past decade or more, I've been asked many times about DTA NMA. My answer, even now, and I say this very nicely, not with exasperation like the driver, is that we are not there yet. We still need to comprehensively evaluate the performance of these models to understand how they perform. The models are complex. As the number of tests increases, the number of parameters increase, and so does the risk of convergence. Even when the methods are available, we might not have the sort of data that we need, and also we don't have easy to use programs, so not everybody accessibility to this method is the methods are limited. And this is what we say in the handbook. So we've updated the chapter 10 of the handbook that deals with meta-analysis. Is that, and this will be online soon, our conclusion is that these methods require further evaluation before they can be implemented in Cochrane reviews. So the take-home message then is that you need to be clear about the test comparison strategy. Currently, we use hierarchical meta-regression models. More complex methods are available, and this is a rapidly developing field, so watch this space. Thanks for listening, and thanks to again Sophia for their help with the work that they've done, and also just to acknowledge my funder and the methods group with whom I've worked on some of the things that I've talked about today. And they're just 2 slides with references if you want to take a picture of that, or maybe later when it's available online. And this is the second slide with the references on. So thank you very much.